Welcome everybody to the osteoporosis long-term conditions webinar. It'll be for the cohorts Tier 1, Tier 2, and Tier 3, and it will be presented by Dr. Jyoti Subramanian, Dr. Habibi, G, and Tushani. I'll let you all introduce yourselves.
Hello. Thank you. Can you all hear me okay? Yeah, okay, thank you. Yeah, thank you. Yeah, thanks for joining this osteoporosis session. We have included this as one of the long-term conditions, although typically we do asthma, COPD, those kind of things. But osteoporosis is also very important because it has got significant morbidity and even mortality as well in terms of fractures. So I worked in Havery for a long time. Then I worked with Dr. Vikram Ratne and their team. We did quite a lot of work on osteoporosis there. And then, I have requested them to come and help us in answering questions about how we manage osteoporosis. I mean, we can manage in primary care, but what is the next step? So Dr. Habibi has taken over the osteoporosis lead now. Thank you for coming to join us today. And we have D Tomaso. She's the senior fracture liaison nurse. So she's also trying to join us today. And then Guy, she's a senior health coach, and she's also going to talk about the health and well-being in terms of osteoporosis prevention. Thank you all to come and join us. Thank you. So I'll try to do the presentation within the 25-30 minutes, and then Guy is going to join us, and then we'll have the secondary care team to help us answering any questions. Thank you, sir. We have the first slide, please. Thank you. Yeah, this is osteoporosis. Now, this is some introduction about ours. I'm very sorry I'm not included Dr. Habibi. I wasn't aware. So thanks for joining us, Dr. Habibi. She's a consultant rheumatologist at BHRUT, and she is the lead for osteoporosis. Thank you.
Thank you. Thank you.
Thank you. Yeah. Osteoporosis, as you all know, is a health condition that weakens bones, and that makes them fragile, causing to fractures. It develops slowly over several years, but unfortunately, we can diagnose only when they have a fall or sudden impact causes a bone to break. And our aim is to detect this even before it happens. Okay. The common injuries in people with osteoporosis is like a wrist fracture or a hip fracture or a vertebral fracture commonly. Next slide, please. So you all heard about osteopenia. So this is about bone loss before they develop osteoporosis. We can take steps to keep our bones healthy to reduce the risk of developing osteoporosis. So obviously, once they develop osteoporosis, we have to give treatment. Next slide, please. So fragility fracture. Fragility fracture, what we define is a fracture following a fall from standing height or less. So that means it's not a fall from the height. It's like a standing height, it's a normal height, and then you don't expect them to have a fracture on an ordinary standing height. However, because the bones are thin, that's why they develop fracture. So they result from mechanical forces that would not ordinarily result in a fracture. So that is what it's called as, that can is described as a fragility fracture. So these kind of fractures do not normally come from low trauma or minimal impact. So reduced bone density is a major risk factor for fragility fracture. Thank you. Next slide, please. So men and women, as you all know, women are more prone for osteoporosis because of the lack of estrogen. So because of the hormonal changes which happen around the time of menopause, which directly affect the bone density. So if women have early menopause, or if they have a hysterectomy before the age of 45, and then also the other reasons, like if they have amenorrhea for more than 6 months, or it could be like people over-exercise or too much dieting sometimes, they may have no periods, that can also cause bone thinning. Next slide, please. If you look at my presentation, this is designed for all kinds of stuff. So it's not very not like a high-fi tier 3. So I prepared to include for tier 1, tier 2, tier 3, That's why lots of slides are very basic. So the senior experienced clinicians may think it's quite basic, but we want to cater for everyone. So in men, the cause of osteoporosis is often unknown. However, as we all know, testosterone can be there even in old age. However, patients or men with low levels of testosterone, they have risk of osteoporosis. Of course, if you take lots of steroid tablets, steroids can cause bone thinning, as you know, alcohol misuse, hypogonadism, low testosterone levels, they can also cause osteoporosis in the man. Next slide, please. So what are the risk factors? So hormone-related disorders, for example, if you have hyperthyroidism, reduced level of sex hormones like estrogen or testosterone, or disorders of pituitary glands, or hyperparathyroidism, so which is basically they develop hypercalcemia because they get the calcium out of the bones. It can cause fragility fractures. So other factors that can increase the risk of osteoporosis, like if you have a family history of osteoporosis, parental history of hip fracture, a body mass index of 19 or less, long-term use of steroid tablets like arthritis, like the steroid tablets are often used for health conditions such as arthritis or asthma. Or if they have an eating disorder like anorexia or bulimia, and the people drink alcohol, like heavy drinking or heavy smoking, and then patients with rheumatoid arthritis, patients with malabsorption problems such as celiac disease or Crohn's disease. There are certain medications that used to treat breast cancer and prostate cancer, for example, like aromatase inhibitors. And finally, if people are immobile, like for example, nursing home residents, because they are immobile, they can have, this osteoporosis. Thank you. Next slide, please. So how do you diagnose osteoporosis and osteopenia? So before you go on to do a DEXA scan, we work out the future risk of breaking a bone. There are two online programs. One is a FRAX score, another is a Q fracture. So there are, I'll come to you in a minute. The next couple of slides will give you the how you do this. Next slide, please. So this is the website for the FRAX score. So what it does is it calculates a score, but when you go on the website, it is automatically defaulted to US, but you have to change it to the UK, and then make sure you have the DEXA results, you put them in, and then it gives a 10-year probability of a major hip fracture or major, like vertebral fracture. The FRAX assessment does not tell who to treat, which remains a matter of clinical judgment. So we can say the score is high, like more than 10%. That means we are higher risk. But in terms of treatment, we use the DEXA scan, and most often we also get, advice from the specialist if the DEXA scan is not clear-cut. Next slide, please. So this is the website for the fracture risk assessment tool. So I have defaulted into UK. So you put the age, sex, weight, and then all the other things like fracture, smoking, whether they have rheumatoid arthritis, glucocorticoid, and then you put the values, femoral neck, and the bone mineral density. We put that one, and that will give us score. Next slide, please. So this is another one, Q fracture. So the Q fracture, this is another one which is there embedded in EMIS as well. Again, it can help to put all this information. This is much more informative than the FRAX one, because it gives lots of, taking into account lots of things like chronic liver disease, chronic kidney disease, Parkinson's, and so on. It also gives an indication of the future risk of developing a fracture. Next slide, please. So this is about how to prevent fractures. This is just a brief slide, but Guy has got more information on this. So you take regular exercise, healthy eating, which contains calcium and vitamin D. The minimum dose of, take a daily supplement, 10 microgram vitamin D, giving up smoking, reducing the alcohol will help. Next slide, please. So how do you treat? So bisphosphonates are the standard treatment we use in the NHS. Of course, they slow the rate that bone is broken down into the body. And then you might have heard something called tibolone. So there are selected patients, the tibolone is used. And then teriparatide. I'm not sure whether it's still available. I've not come across any patient teriparatide I don't know, it's still in the system, in the treatment line, but I've not seen anybody on teriparatide myself. And finally, denosumab and romosumab. So they work by slowing down the rate at which the bones are broken down and speeding up the rate at the cells built for. So usually, the bones are broken down, the new bone is built, but this helps with this. And recently, romosozumab is licensed and is on the BHR formulary. Next slide, please. So vitamin D supplements, we talked about calcium and vitamin D. So the recommendation is take 700, but obviously you can go up to 1,500. So taking more than less than 1,500 milligram per day is unlikely to cause any problems. And that's what lots of nursing home residents you might have seen that what we call alcohol D3, similar to that, similar medications are in the people are taking in nursing homes. HRT is an interesting topic. Like HRT can be taken by women who are going through the menopause to control the symptoms. They also keep the bone strong and reduce the risk of getting osteoporosis. If the patients already have osteoporosis, it can help to strengthen the bones. If you have early menopause, then obviously people take HRT. It's not a hormonal contraceptive. It's more like they have a Mirena coil along with the estrogen HRT. So that help to prevent osteoporosis. Next slide, please. So living with osteoporosis. So this is about support available. There is a NHS website, Preventing Falls, and there is a free osteoporosis helpline. Given the telephone number and the nurses, they're quite helpful. Like some of my patients have ring them, asking for advice and all. So if you have a fracture, then obviously the options surgery, physio, OT, occupational therapy, and so on. And pain is a major problem. Some people are significantly affected with pain. That's a major problem with hip fractures and vertebral fractures in old age. Okay, next slide, please. Right. So these are thanks, Dr. Vikramatne. We have had some questions, and then I sent to Dr. Vikramatne. She has given some information about this, about what to do 3 years or 5 years. So this is the individualization. So if you have continuous fractures while on treatment and the risk factors are continuing, then they may have to continue long term. So generally speaking, if there is a one fracture and then they have treatment, the risk is stable, then obviously they end the treatment 3 to 5 years and then do a DEXA scan afterwards to decide about the follow-up. Next slide, please. Right. What happens if they fracture on bisphosphonates? Compliance. So check the compliance first. So, it's not easy to take this calcium and vitamin. They are very big tablets and people struggle. As a GP, I have the experience of people saying, no, I don't want to take it. And they say, I'm taking it, but they don't. The other thing is alendronic acid. You have to sit for half an hour once a week. You remember the date, a day, either Sunday or Monday, tell them, but sometimes people do forget about it. And then you can test for bone markers. The bone markers, like there's a specific bone marker in alkaline phosphatase. And there are something like osteoclastin. I have never done myself, these kind of bone markers. I suspect, it may be requested from the secondary care consultants. And obviously, if they still fracture bisphosphonate, the next option is going into denosumab or the other ones. Next slide, please. So who needs vitamin D and calcium? So do we put them on everyone over 50 or everyone nursing homes? So, these are the websites about giving calcium and vitamin D. I've gone through them. So taking regular calcium and vitamin D in the diet, if you have a regular diet, like, eating, drinking milk, normal milk, vegetables, they all give 700 milligram of calcium per day. As long as you eat a healthy food and normal activity, you can get it. But vitamin D, in winter, and not winter, you won't get the vitamin D, so the supplementation with 10 microgram might be useful. But generally, the idea is nursing home residents are encouraged to be initiated on calcium vitamin D because of their immobility. Next slide, please. So family history of osteoporosis, that's really important. So anybody with a fragility fracture, or if they have risk factors for osteoporosis, it's really important to ask the family history because that makes the treatment very important, because if they have, especially in women below the age of 50, if they have a fracture, then obviously there is a above the age of 50, they have high risk, then obviously it has got implications in managing these patients. Next slide, please. Finally, this again in a HRT, will that replace bisphosphonates? No, the answer is no. It has got, definitely it's got value in selected patients, safe and effective and inexpensive treatment. It can help to increase estrogen levels to prevent bone loss. However, they do not replace the bisphosphonates. So that means there are not many studies comparing the HRT with osteoporosis drug treatment. But HRT probably reduces the risk of breaking a bone. So if I am right, HRT alone is not osteoporosis. If the patient has got osteoporosis, we don't leave them on HRT alone. So they need osteoporosis treatment as well. Next slide, please. So this is a recent medication which is come in the market and is approved by NICE, and also it's in the HR formulary. It's only specialist use. It's an injection. So once a month for 12 months, along supplementation with calcium and vitamin D. I think those patients we refer to secondary care, we have this injection for them. Thank you. Next slide, please. So, I mean, unfortunately, no, I don't have the current guidelines. I think what I understand is the current guidelines are being developed at the moment. And there are I was looking at the NICE guidelines and the NOGG guidelines, but they're quite long. But I can't see anything like this, like a chart where you do this. But still, I find this is still useful, although it's an old one, which we did an audit a few years ago. But this is a baseline, and still, it's useful. That's what I think I use it. So this is the BHRCC. Dr. Vikramatne developed this guideline a few years ago when we did the audit project for our region. So the fragility fracture more than 50, then obviously you have to exclude any secondary causes, like patients may have hyperthyroidism, hypercalcemia, celiac disease. And there's one thing I wanted to emphasize in fragility fractures: don't assume all the fragility fractures are osteoporotic, because patients who got metastasis cancer, like for example multiple myeloma, prostate cancer, they can also cause fractures, but that's why you have to exclude them by doing other screen like myeloma screen, PSA, the celiac screen, and these are for the recent secondary cause for osteoporosis. So I do a DEXA scan. Then in the DEXA scan, the T-score is less than 2.5, then you start on bisphosphonates. And then you can go on to risedronate if they are intolerant. And then repeat the DEXA in 3 to 5 years' time. So if the DEXA scan is normal, then you stop treatment and monitor them. And if the DEXA scan still shows deterioration of the bone mineral density, then we refer to the secondary care. Similarly, look on the other side, if you have like clinical risk factors, right? Clinical risk factors, age more than 50. So they don't have a fragility fracture. For example, if somebody is on long-term steroids, then you do a fracture risk assessment using this, the FRAX score or the Q fracture, and then decide on whether they need a DEXA or not. Depending upon if the score is really high, then go for DEXA. If the score is not high, then monitor them, but it is individualized. But if there is any doubt, then ask for advice. Nowadays, we have advice and guidance for all osteoporosis from the rheumatology department. Okay, next slide, please. So, what are the patients we refer to secondary care? So, people who are not able to tolerate oral therapies, fractures despite having oral therapies, then secondary osteoporosis like anorexia, malabsorption, steroids induced osteoporosis. Vertebral fractures, again, I have not come across teriparatide. Male osteoporosis with comorbidities, like for example, they have low testosterone, and if the T-score is more or less than -5, then this is the D-termososis is extremely good. See, I have got lots of positive feedback from my patients. She managed them very well with the fracture lesion clinic. So the contraindications for bisphosphonates, if they have a reaction, if they have hypocalcemia, EGFR. So that's why really important, because lots of our patients have got osteoporosis and CKD as well. So we need to keep an eye on them when we do the medication reviews, make sure that they don't have renal failure or CKD creatinine less than 35. think nowadays, we have pharmacists, clinical pharmacists looking at them. Previously, we used to struggle, but now, we have the help of clinical pharmacists. They actively monitor this. Because the bisphosphonates can help cause ulcerations, like, people with problems in the esophagus, then obviously you have to consider alternative options. Okay, so maximum 10 years of therapy. So the bisphosphonates, not more than that. I do not know whether we use denosumab anymore. I think we were using a few years ago. I'm sure still using it. Okay, that's fine. The next slide, please. Right, okay. So this is the, the fracture risk, we were talking about it. I'm going to leave this slide. It's a very busy slide, but obviously, if you have any questions, I think we could ask the consultants about, the question most people have is, what do? We have a fracture risk of 10% and do a DEXA scan. That's a normal procedure. Are there any places wherein, we don't do a DEXA scan? So that's a question we may have at the end. Okay, next slide, please. So this is just the, it's the same thing. It's about giving the management of the osteoporosis, the same thing based on the guidelines we had at that time, just what we do for alendronate, what we do for acetonide, what's for denosumab. Next slide, please. But these slides will be available for, in the website, the CPN website, so we can always have a look. This is a quick view of the pilot, we did a project on in osteoporosis in my surgery. I was working in Maryland at the time. So we had about 14,000 patients. So we did a search and find out whether we were managing appropriately based on the guidelines. Next slide, please. So, the challenge was search, because not everybody is coded. So we were searching under coding for osteoporosis, coding under fragility fracture, and coding without any coding. Now, if you look at some of them are on medications without having any coding. So we did search under all of them. Next slide, please. So based on the guideline you have seen earlier on, so the question is, you found out osteoporosis, you had a DEXA scan, you had a treatment 3 to 5 years, because there are patients who are taking for 10 years, 15 years, because sometimes if you don't do a medication review, then they will be carried on. But as I said now, because we have the benefit of the ARRS staff, the clinical pharmacists, is much more better now to identify those patients. So in 2018, we were, 78% of patients were followed on, where we were following the guidelines, but it has improved to 81% after the audit 2019. So it was very useful. I presented in our local meeting so that, it was implemented in local practices. Next door, please. Next slide, please. So these are the references, NICE, NOG, and all these things would be useful. Next slide, please. I think so. Let me finish my presentation. And if you are okay, we can leave the questions at the end so that we can have a G now. Yeah.
Thank you very much. Should I share your slides, G?
Yes, please. Yeah.
Yes.
Like
Okay.
senior health and well-being coach.
Fantastic.
Please. Hi everyone, whilst we're just waiting for the slides to come up. Brilliant, thank you. I'm G, the health and wellbeing coach. I'm a certified naturopath, nutritionist and yoga specialist, and also supporting the educators on the personalised care side of delivery. I'm really passionate about bone health due to lived experience, and I've got 10 years experience working in and around osteoporosis and bone health conditions. So I facilitated the vitamin D3 guidelines way back in 2014. So next slide, please. I'm just going to be sharing how the personalised care team can really make an impact on patients who present with long-term conditions, and particularly the osteoporosis. As a health and wellbeing coach, what I find in my clinics is really supporting patients moving from their fear response, so really transforming fear into freedom. And that fear can show up in many ways. mainly as a freeze response, because bones are our structure. You know, it gives us our mobility, gives us our freedom of movement. And when patients are diagnosed with osteoporosis or osteopenia or any bone condition, there's a level of pain that they have to manage. And more than anything, it's really teasing them out this fear response and letting them know it's okay. We have support networks, we have community, we have the FLS clinic, and it's signposting them to the community resources, helping them through their finances. What have I written here? I've written the social prescribers are excellent, and care coordinators at providing home hazard assessments, so ensuring that patients have their environment assessed to prevent ongoing issues. And really, for the health and wellbeing coach, it's looking at how we can support them with pain management, with signposting them to exercises, and to develop their strength. Next slide, please. Okay, so I have teased out information from the National Osteoporosis Guidelines, and I think as personalised care roles, we need to start looking at the lifestyle guidelines that are available for long-term conditions to perhaps armour ourselves and be able to signpost patients to the right support that's out there. Next slide, please. So there are no real guidelines. I know I've said, let's look at the guidelines, but there's no strict guidelines on healthy eating and exercise for osteoporosis. So this is generalized, and I think Dr. Jyoti has already touched on calcium and vitamin D. I'm really going to focus on some of the weight bearing and resistance exercises. We talk about the health benefits of physical activity, but really, you know, what does that look like? Because patients with osteoporosis or bone conditions or long-term conditions, you know, will have elevated mental health, will play on their mind. The disease or the lack of movement or the change in their lifestyle starts playing on their mind. And really, it's down to us as the personalised care team to help them manage this. And here you can see an organogram where I've just pulled out and teased out some stats of the health benefits of physical activity. Next slide, please. I think Dr. Jyoti has already touched on this, but I'm a huge advocate of vitamin D. Vitamin D is not a true vitamin. If you think about the word vitamin, it's about vital mineral. But really, vitamin D, its source is the sun. So actually, it's considered a prohormone, and it's necessary for all of our endocrine functions. It's vital for healthy bones and teeth because it aids calcium absorption. And here I've just put some of the guidelines for the recommended dose for vitamin D. If your vitamin D levels are at replete, meaning they're normal, then yes, 10 micrograms a day, which is 400 international units, is sufficient. But really, a deficiency loading dose is around 4,000 international daily. That's about 100 micrograms, which is essential over the winter months. So, like I said, I'm a big advocate on this, and you can find all of the information on the links that I added to these slides. Next slide, please. Sunshine, again, is the natural source of vitamin D3. And I'm just asking you as healthcare professionals, how much sun do you actually experience during your day? Because we enter a clinic in the morning and we don't leave until the evening. So are we getting our daily dose of vitamin D3? And this is also dependent on our skin sensitivity and our type. And I've written here, if it's Fitzpatrick classification, type 1 to 6. If you have sensitive skin, then between 20 to 30 minutes of midday sun is sufficient. And this is on our arms and on our legs. Darker skin, we require a lot more, hence going back to our native lands, India, Africa, or going on holiday really does us the world of good. I have put some links there for the Royal Osteoporosis Society if you'd like to learn more. Dietary sources of vitamin D include oily fish, and also shiitake mushrooms, but you need to eat at least 100 grams of shiitake mushrooms to provide your 10 micrograms of vitamin D daily. And I've also put there, as a nutritionist, consider tissue salts, because it's not just calcium and vitamin D3 that's necessary for bone health. We're looking at things like silicon, boron, and tissue salts is a really easy way of delivering this to the body on a daily basis. Next slide, please. Okay, so on to exercise. Proactive prevention, so regular weight-bearing exercise. Now, there is no official guidelines on exercise for osteoporosis, and I know we've got the falls clinics, we've got physiotherapists that specialize in exercise for osteoporosis, but really think strong, steady, and straight. So we're looking at building bone mass and developing muscle strength. The easiest way that I demonstrate this to patients who perhaps come to my clinic is, something like a resistance band. So here I've got a resistance band, placing it between the hands and literally just stretching the arms out and pulling and pushing against the resistance band. This is kind of like probably the easiest demonstration of resistance. It's not difficult, and you can do this seated rather than standing, or going to a gym. So all of these exercises can actually be performed in your home environment, but obviously it's very good to get out and meet other people. Improving balance is key to developing muscle strength as well, and posture. And I think you'll find in some of my other webinars, I've demonstrated seated work, keeping the muscles active so that our posture, our bones are stacked. So we're preventing long-term deterioration of our bones. And also it's about being proactive whilst we're seated in kind of strengthening our bones. I've put a link here to some research and evidence about exercise that can increase bone mineral density and reduce falls risk. Next slide, please. Again, this is about regular weight-bearing exercises. So this can be anything like brisk walking, keep fit classes, perhaps even a game of tennis. And I've written here power plate, Pilates, and yoga. Now, there was a lot of evidence using the power plate, and if you're interested, you can Google this. There's actually some research about developing biodensity, so developing bone density using the power plate. A lot of evidence behind this, and it's used in care homes, and they've had quite a lot of success. So what I'm saying here is, even if we are unable to get out and do some physical activity, there are other methods that we can use to really start supporting our structure, our bones, and developing. So it's about stepping away from fear. It's about supporting patients where they are and letting them know that there's hope and there are things that they can do, meeting them where they are. And here there's just some general advice about how much physical activity we need to do on a daily basis or in over a week. Next slide, please. Looking at high impact weight-bearing exercises. So this is where your feet and your legs and your structure supports your weight and strengthens your muscles, ligaments, and joints. We can actually do this whilst we're seated in our seats by stretching our legs out in front of us, planting our feet firmly on the ground and just dragging the feet back towards the seat against resistance, and you'll feel your muscles engage almost instantly. And if you then push down with your feet into the ground, you're now experiencing some weight-bearing exercise. Very simple. Things like running, skipping, dancing, and aerobics are all very, very good weight-bearing exercises. And then resistance, which I've just demonstrated using a band. If you don't have a band, you can look at press-ups. And this doesn't have to be done on the floor. We can do it against the wall. So really just pushing our hands against the wall and pulling our body away. We can do it whilst we're seated at our desks, so pushing the desk away as we lift up. So these are really simple exercises that we can introduce into our day. Next slide, please. And other lifestyle factors that we need to consider to prevent osteoporosis, things like quitting smoking. So as a health coach, we'll be looking to change behavior and habits and really supporting these patients to quit some of these habits. Also limiting your alcohol intake. Next slide, please. So falls prevention, I'm not going to speak too much of this, but what I'm going to say is that social prescribers, care coordinators are really, really good at requesting home hazard assessments for patients and helping to make simple changes at the home that can help reduce the risk of breaking bones and falling. Also things like vision tests, and as we know with long-term health conditions such as heart disease, dementia, or low blood pressure, there's always a concern of dizziness and that brief loss of consciousness. So falling is always an issue. So there are always things that we can do to support patients. Next slide, please. I think I've already spoke about this in one of my previous webinars, so it's just a very brief overview with patients who present with osteoporosis that will also show up with pain. So pain and fear are the two things that we will look at. And so as a coach, we can offer encouragement, hope. We can empower patients and motivate patients to take action by building confidence. And that's by actually showing them what they can do rather than focusing on what they can't do. And we know that pain will change our mood, our behavior, and really it's about supporting patients to break those cycles and step into a place of peace of mind, and what does their new joy look like? Next slide, please. So in a session with a patient, we'll be looking at listening to their story of pain or fear, what makes it better, what's making it worse, where are they stuck, and then looking at supporting patients to find their ability to respond to their long-term condition. So what's helping them, what's working well for them, and what more do you think that they could do to self-manage, to support themselves, and then really building that support structure around them. I always teach my patients to good posture techniques whilst they're seated, and also functional movement. So this is stuff that they can do whilst they're carrying shopping, whilst they're getting in their car, whilst they're seated watching TV. So these are things that you can do in every moment. There's a great resource here, which is called Flipping Pain, and they have all sorts of stories, resources. So it engages with patients to make them feel that they're not living this through this pain or fear alone. Next slide, please. And here's another resource, which is called Tame the Beast. There's a brilliant 3-minute video on this, which I highly recommend all patients see who suffer from pain. Next slide, please. And here are some resources which you might find useful. Thank you.
Thank you very much, G. That was wonderful. Thank you.
Is Dee here today, is he? Has he joined?
Yes. Yes.
Okay.
Dee has joined. Di Tommaso?
Oh, hi. D is here, but I think. Oh, yes. Can you?
Yeah, I'm afraid I
talk?
haven't
Oh,
got a camera on this computer, so it's probably would be a welcome relief to all of you if you saw me, but I hope you can hear me all. I believe I've been asked to give a brief overview of the FLS service we have here at BHRUT. It's can be referred to as the Fracture Liaison Service or the Fracture Prevention Service, and our purpose is to identify, treat and prevent secondary fractures, okay, and identify osteoporosis. We also run a telephone helpline for patients, relatives, my GPs, colleagues, for specialist advice and health education. So all patients over 50 are identified through either fracture lists, GP referrals, the inpatient wards, outpatient clinics, and sometimes the patient will contact me directly. We carry out a comprehensive bone health assessment, which includes if necessary, a DEXA scan, where patients are seen the same day in our one-stop clinic immediately after their scan. When they're seen in clinic, they're given the results of their scan, and we carry out, amongst other things, a falls assessment, lifestyle assessment, their family history, and we also organise screening bloods to rule out any other secondary causes for osteoporosis. We supply them with information regarding lifestyle choices, nutrition, and also any treatments that may be required to improve their bone density. They're all signposted to the Royal Osteoporosis website, who have got a fantastic website full of advice on things about their diet, exercises, and they've even got little exercise videos on there, which is handy for patients. They've got, you were just talking about the pain there, they've got exercises for instance, for patients that have suffered vertebral fractures. So it's really helpful for them. Any patients that are recommended for osteoporosis treatment also receive a telephone review follow-up after 4 months to ensure that they're tolerant to the treatment and to make sure they're adhering. We do a 1 day a week, one-stop clinic. It's a full-day clinic where, like I said, the patients are seen, given a scan, and then seen immediately afterwards. I do a half-day denosumab clinic where patients in the Havering area are initiated on denosumab. My colleagues at King George Hospital will initiate the Barking and Dagenham and Redbridge patients, and I have a colleague at Brentwood Community Hospital who initiate the denosumab there. And then I do a telephone clinic on another day, and that's the 4-month follow-up, but also that can be initial contact with patients where referrals have been received in, where I need further information as to whether to proceed with the DEXA scan. What the FLS is not for is for routine osteoporosis follow-ups without fractures. They should go to the general rheumatology. Our referral system is not on ERS at the moment, so I know there is a referral form. I'm not sure how many practices are still using them, but a letter to me will do. I do also receive some by email. I receive some from specifically the orthopaedic clinics that take place in outpatients here, and also the inpatient wards. So that's my overview of what I do. Has anyone got any questions?
Yeah, thanks, Dee. Thank you very much for the excellent service. Because I got, like patients being picked up in A&E, and then they come to you. Otherwise, what happens is that things get missed.
Yeah.
Like people have fractures, but not screened for osteoporosis. Occasionally, it does happen because if they come in briefly and then sent home, and then the fracture is diagnosed later, sometimes it does happen. But most often, they have been picked up in A&E. Thank you. Thanks, Dee.
You're welcome.
Thank you.
Thank
So,
you. If I may
yes,
add,
Meena?
D, sorry, I'm Tushani, Dr. Vikramaratne. So I must add that Dee does all this by herself on a part-time basis. So it is a massive workload that she does by herself, and she's extremely thorough. So I think, take the opportunity to thank her specifically because of the workload that she's doing more or less single-handedly. Yes, Dr. Jyoti.
Thank you.
Yeah, okay. Thank you. Yeah. Yeah, I think we'll open the audience can ask questions now. I'm sure people will have questions, and I will be glad to hear from the consultants. So you can put it in the chat box as well. If you have any questions.
Yes, I'm happy to answer any questions. Before I start, could I highlight a few points for
Yes,
the
please.
colleagues in the audience? First of all, the Royal Osteoporosis Society has a link where the patients by themselves can calculate the risk of a immediate fragility fracture. So I think that is important, particularly for patients who we consider but in the primary care who are at high risk. They can self-assess themselves, and they can, if they want, they can bring the printout to the GP, or they can address that directly with the general practitioner. The other issue is with regard to the vitamin D. We do emphasize everybody to take vitamin D during the winter period, and the 10 micrograms daily is available as a non-prescription over the counter. That comes to about 400 units. So 10 micrograms is equal to 400 international units. And that is the kind of minimum dose. So we ideally recommend 800 units per day. And this is important during the winter time. On a personal experience, I did have my vitamin D checked, and it came as less than 10, in other words, unmeasurable. So going back to the G's talk on how we are kind of confined into a clinic from morning to evening, no sunlight, in a closed environment, no windows. So that again highlights how important, even though we feel we are, good and healthy, it's very important to top up that vitamin D. Just one quick question to G, if I may ask. Can we refer patients directly? Because I think in terms of your pain management, it's quite comprehensive, and it's exciting for the people with chronic long-term disease, especially the rheumatoid, who you really can't control the pain all time with the medications. So how can we refer these patients to you?
So for the personalised care team, I think every PCN have their own referral pathways, but generally GPs can refer through EMIS. You'll find the social prescribing referral portal. It's called Joy, and so you can refer through the Joy referral system, which comes through to the social prescribing team, and then patients are triaged to obviously who they need to see, be a health wellbeing coach or social prescriber.
So we can't do a direct referral from the secondary care.
Sorry?
So we can't do a direct referral from the secondary care. I hate to add more work to the GPs.
I'm not sure, actually. I think patients can probably self-refer.
Oh,
so
okay, that's
if
good.
they're aware, if you inform them that, please go back to your primary care GP and ask them if they have a health and wellbeing coach for pain management, then you can probably do it that way, so they can self-refer.
Okay, thank you.
Can I add some points, Dr. Vikramaratne? Yeah, basically, there are something called PCNs, and I'm sure PCNs, and like lots of PCNs have got health and well-being coaches. Some of them don't. So it depends upon the PCN, and similarly, the health and well-being coaches, not everybody's, at the same speed. Like some people are trained in certain areas than others. For example, pain management, they can signpost, but some of them, like you have lots of experience in that area. So they don't need to see a GP. So basically, the patient, they can go back to their surgery, the receptionist, then they can arrange an appointment to source and prescribe it directly without seeing a GP. Yeah, you okay?
Yes, that's good. Thank you very much.
Yeah,
So
okay,
they are
yeah.
called PCN.
Every PCN, yeah. Each, for example, if you take about Havering, so Havering we have about 3 PCNs at the moment. So
Okay.
I mean, the easiest way for us, is, they give the patients, they can self-refer to a GP surgery where the health will be. But unfortunately, they don't have, not everybody has got advanced level of management in every PCN.
Okay. Thank you. Thank you very much. That's helpful.
Yeah. So can I ask that question for on behalf of everyone? The one which struggles us is the calculating the scores. We do the scores, and what do we do with them? We do the DEXA scan, we put them in risk calculating, but does it matter in terms of management? Because what we know, the DEXA scan shows the score is less than 2.5, then yes, you go for treatment. We know that. But there are patients whose DEXA, the T-score is fine, like they score osteopenia, but the FRAX score is high. There are some dilemmas. We use advice and guidance. But is there anything like a general advice you can give it to the GPs?
Yes. One thing you can do is in the FRAX score. FRAX is originally it was started by the Sheffield University. You got to make sure that you go to the UK component, and when you add the FRAX details, and if you are in a dilemma whether to treat or not, one good thing is that underneath that box is a NOG guidance.
Okay.
And if you click on that NOG guidance, then it will come as red areas and green areas.
Okay.
So if it comes into green areas, they usually put a tick box across and say, that means lifestyle modification, other alternative ways. But if it comes as red, right on the top of the red area, then it's a definite indication for treatment.
Okay.
Sometimes you come it in between the red and the green areas. So that is when the individual judgment take place. So those patients, you look for a secondary cause. It is quite surprising how many celiacs we tend to detect with just the screening. And so you look for this, and the prostate cancer. That's the second most common thing. So to look for the screening, and then you can decide on an individual basis whether to treat or not.
Good. Yeah, very useful. Thank you. It was a very useful session for us. So, although compared to asthma, COPD, hypertension, not much importance is given to osteoporosis, generally speaking. But however, in terms of morbidity and mortality, lots of patients who are frail, and if they have a fracture and that's it, their lifestyle, the whole thing changes. Their life, not just style, their life changes in a big way. It's got a huge implications for the patient, families, and the system and the NHS itself. And the prevention is the better way. And obviously, we are putting, as GPs, we're trying our best to help these patients. And hopefully, with more awareness, things will improve, hopefully. Okay.
May I just say, before we think about closing off, or actually as people are thinking about questions, I have put in the chat the link for you to fill in a survey, basically asking for your feedback about what you thought about this webinar, what you think is important to us. It's very important for us in terms of, trying to know what to do for next time or what worked. And when you complete it, I will send you a certificate of attendance for this particular webinar. Thank you.
So can I request the speakers to stay after the meeting? Is it okay? Yeah. Yeah, speakers to stay just a few minutes.
I do have a question actually about vitamin D. If you stare, I'm right in front of a window right here. It's through a window though that I'm getting the sunlight. It's not the same, is it? Or is it the same? No, it has to be outside. Okay, I thought so.
Anyway, if there are no questions, on behalf of all of us from the primary care team, we thank the consultants, Dr. Vikram Ratne and Dr. Habibi, and D, Mr. D, you're really great, and our health coach G, and the organizing Yasmina. It's really good. It's a very good topic, but as I said, it's not as famous as the other ones, but however, it's equally important. That's why we thought we'd bring it in here, and hopefully, we try to do these sessions again next year and see so that we improve the awareness among our primary care clinicians and other staff.
Yes, thank you very much for inviting us as well. I hope everybody learned something. And as I said, if there is any query, feel free to contact us. We have the advice guidance line. We have these email. So advice guidance is quite helpful. We are the consultant will directly respond. So feel free to liaise with us. We are more than happy to help. Thank you.
Thank you, everyone. Please don't be shy about filling in the surveys. It's extremely helpful for us. I've had a few responses, but it would be great to get everybody to just 5 seconds of your time just to give us your thoughts. Most of it is multiple choice. You'll only have to write your name and you'll get a certificate when you complete it. Thank you very much. Thank you, Amanda. I hope to see you soon. Thank you.
Thank you.
Thank you, Vera.